So, hello everyone, I'm Katie. I think I know most of you guys. I'm one of the ED registrars with the suspect in PEDS now. I'm just going to talk to you about leg, ankle and foot injuries. Talking about leg, we'll start from the top. We're not going to do pelvic injuries because I think Sarah is doing that later. All the presentation is all based on my little guide I've written few months now, and we're trying just to see how people like it. So it's a 10-question guide with 10 questions about each fracture. So as I said to Sarah earlier, that I'm quite happy to, if you want to stop me, ask me anything, just put it on the chat. I don't know if Sarah's happy if people ask me, like, verbalize something. I don't mind either way. I think it's better as we go to ask questions if you have to add on anything or your thought, if you disagree with something, and we have a chat, because then you forget things and it's more difficult to go back. Okay, so starting with femoral shaft fractures. The first question is, how often do they occur? They're not very often. It's 1.6% of pediatric fractures. They're quite severe though. It peaks in early childhood and early teenagers. And this is because of how it happens. How do they occur? In older children, like teenagers, it's high energy trauma, like motor vehicle accidents, 90%, most of the time, 90% of the time. With the little ones, usually it's trampoline injuries, and we saw that a lot during the first lockdown when everybody had a trampoline and they were in the house, they were playing in the garden. That was quite an increase of these trampoline injuries in the department. These ones that they are under 4 years of age, we need to bear in mind that it might be a non-accidental injury, and this is the 30% of the femur fractures that are associated with NAI when they are less than 4 years old. Not to mention, of course, the not yet walking ones that must to be ruled out. How did they have a femur fracture if they can't even walk? Always think about it. How do they look like? So the child will be in pain. They will be very reluctant to walk on it. They will be swollen, and maybe bruised. So most of the time it's quite swollen. They will be unable to even lift the limb off the bed when you examine them because they're in pain, they're crying. It's quite obvious most of the times. Sometimes with the chubby thighs, with the very little ones, the signs are not that easy to see, but still we've got a history, hopefully, and even if there will be swelling and there will be a difference between the two. It will be more hard with a broken one if you feel it, and there will be obvious pain when you palpate it. They are, as all long bone fractures, they're like the transverse fractures, the oblique fractures, the spiral fractures, and the comminuted fractures. You always need to, if you have an X-ray later, you always need to describe it, make the orthopedics happy as well. And just it's easy to communicate when you just write the right things, be able to recognize it. Do I need an X-ray? Of course we do. I need an X-ray. We need 2 X-rays. We need an AP and we need a lateral X-ray as well. They must show the full length, including the hip and including the knee joint, the full length of the femur. They look like that if they're displaced. This one is a little bit, it's a 7-month-old with a low energy spiral femoral fracture. You can see it there on the first X-ray. On the second X-ray, he is on a spica cast. This is the treatment. We'll talk about that in a little bit. You can see how the spica caster comes on. And then you can see that is, you can see the callus, and you can see that it's healing nicely after 4 weeks after the injury. Do they need respirator? Yes, they need to be seen now by the orthopedics. How do we manage them as soon as they come in ED? So if there are other injuries, of course, you just put in practice your ATLS. If not, other injuries, you need to examine the patient. And the most important thing, sometimes you don't even have to examine the patient. You just see by the end of the bed, you hear the story, and you know that they need adequate pain relief. Most of the time we give intranasal opioids like fentanyl or diamorphine or IV morphine we're happy to if we have time for access. Sometimes parents have already given paracetamol, ibuprofen, but they're still in quite a lot of pain. It's quite painful. We've got the Thomas splint, any skin traction that your department have available. That should be applied if the orthopedics are busy, if we can't see them, it can't be applied, and they give a lot of pain relief. Sometimes paramedics have already applied it when they come in the department, especially with older patients, the teenagers, big lads, they do that quite a lot. And they look like that. We have in our department, we have both of them. We've got a Thomas splint, and there's a traffic-like system, and it's easy to apply. This one is easier than the old-fashioned one, but we have both of them in Leicester in your departments. And in EM3, there is there are directions nicely how to put to apply splint on, traction splint on. What else can you do? You can do a femoral block under ultrasound guidance, as it is now, the guideline. It helps to perform with a pain. It will help. Sometimes you can just go down with your ultrasound and scan the leg, and you can see the fracture there, and then send the patient to X-ray after that, because you need the images obviously. But it does work nicely for children, and it makes them a little bit more comfortable, and you get better images because they're more cooperative when they go for X-rays. And it's less stressful with parents afterwards when the child is not in such a lot of pain. Okay, so when the X-ray is confirmed, as we said, we need to bear in mind the non-accidental trauma. So we do a safeguarding referral if we are concerned, or straight away, a regular one or a more urgent one. So treatment-wise, the aids, the fracture pattern, the location of the fracture, where it is, if there's any soft tissue damage or associated injuries, then this is how these are the things that will influence the treatment modality. In younger ones, as we said, we do the spica plaster cast. I don't think so we do them in A&E in the department. They do the orthopedics, we do it. If they're happy to, and this is for the little ones. For over 5 ones, they sometimes consider operation nailing it. Do I need to organize follow-up? They need follow-up with fracture clinic after they are discharged by orthopedics. So at that stage, for femur fractures, I would say let the orthopedics see, then they will organize everything. Always communicate with them. They usually are admitted to hospital, so you don't need it for anything. But always worth to communicate with them. What do I advise the patients? They're usually very good. The outcome is quite good. They look impressive, but it's a long, strong bone, so the outcome is quite impressive. And always, if you have complications or not, especially the malunion, depending on the location or the method of stabilization of the fracture. They can cause some bleeding, another complication, but usually it's not going to cause clinical signs of shock. Sometimes, but this is very rare, a leg length difference. This can overgrow sometimes, up to 2 centimeters in the next 2 years after the injury, or the fracture can also heal in a shortened position, which are quite rare. If you have if they present straight away, if they don't have any more union, if they do the right treatment, usually they do really well. Okay, going down now, knee injuries. Okay, so they're so common in children because they play around, isn't it? But most of the times they're going to be a sprain. They're not going to be something serious. But I think we need to know what to see, how we look at the X-ray, what injuries are there, and which ones we need to rule out. How do they happen? Of course, like children are running around, they go on bicycles, they do sports, they're jumping around. For older ones, again, we've got motor vehicle accidents with direct trauma to knee. But the more common ones, they're physeal and avulsion fractures than the ligament injuries, because the ligaments are stronger than the bones at the younger age. So they cause avulsion fractures and physeal injuries. Okay, how do they look like? they come in pain, they cry, they're reluctant to walk on it, it's swollen, it's bruised, you may have some grazes, obvious injury of a little bit superficial skin injuries, all sorts. There can be an effusion, which can suggest a vaginal or ligament injury, a big effusion. If they cannot walk on it, or even more importantly, if they cannot do straight leg raise, that would concern me a little bit, because it might suggest, it's very useful to suggest that the knee is not very stable. And then when that happens, even when I would not, even in the scenario that I would not be able to see any obvious fracture or any other injury, but they, even after good pain relief, they cannot straight leg rise, then I would ask orthopedics to have a look at them. We have the dislocation of patella. We usually comes like that. It doesn't look nice, but easy to treat most of the times. The child will come in a like semi-flex position, like those two. It's lateral and anterior always, and all you need to do is just hold the patella around there and straight the leg. There's nowhere else that the patella can go apart from the right place, if you can do it. If they can bear the pain, give them strong pain relief and just do it. Most of them, they come and it just is in place spontaneously after it happened, and then we just need to make sure there's no other injuries. This is how they look like. Okay, do they need x-ray? They need x-ray. We can, when the child is more than 12 years of age, we can apply Ottawa rules as we do for adults. So if they is unable to flex to 90 degrees, if the tenderness over the patella or at the neck of the fibula, or if the child is or was unable to wait there at the time of injury or in hospital, and they are unable to straight leg raise, so then we do an x-ray. For the less than 12 years of age, I think it's this very clinical decision, but most of the times I think we end up, if it's not just some grazes and they not, like if they had some paracetamol now in the department, they feel a little bit better and they just walk in the department, they don't limp at all, or they can move the leg and the examination is unremarkable, just a little bit of tenderness around the knee, no swelling, then I will let them go, wouldn't do an x-ray. But other than that, then when you're concerned, you do an x-ray, it's not going to do any harm. How do they look like? So these are all normal x-rays, just to remind you a little bit of the, I'm sure you know the anatomy. Just for children, because we've got epiphysis, the growth plates, and the metaphysis. It's always, most of the joint injuries, it's all about them, especially for the legs, the epiphysis, the growth plates, and the metaphysis. And the worry is to damage the joint itself. Okay, so what are we looking on the x-ray? Is there an infusion? First thing. So if you look at the knee, if in the normal knee, we have, as we have in the elbow, the fat pads, we have kind of fat pads there. We've got the suprapatellar anterior fat pad, and then the suprapatellar posterior fat pad. Usually you can see the fat pads and there's nothing in between them, or you can see a little bit more tense area, just light, which represents the suprapatellar recess. If you have an infusion, so then you've got the suprapatellar fat pad, the anterior one here, the posterior one here, and then you have the infusion more dense area, and there is like a lever because the patient hopefully had the x-ray as they were sitting down, and the lateral x-ray. So you're looking for an infusion first. Another thing which is even more important because is the lipohemothrosis, because and how you can see it. So you can see the suprapatellar fat pad there, the other one there, but then between you can see a more dense area, which is the fluid, and there is a very clear lever there, and this black, like less dense area than the fluid, and this represents fat that comes out of the marrow because there is a fracture somewhere. I can't see a fracture around there, but I can see that. I'll ask the orthopedics to see them. I'm not happy to send this one home. What else do we look? We look at the bones. So again, as with elbow, we've got ossification centers. We're not using them as often, these ones. But I think it's worth mentioning that we've got tibial plateau, which is present at birth. The distal femur is up to 6 months. Fibular head is 2 to 4 years. The patella comes 3 to 5 years, and then we've got the tibial tuberosity later at 10 to 12 years of age. What are we looking at the bones? So we have the tibiofemoral alignment. So if there is a line that goes at the lateral aspects of the femur, just goes down to the lateral aspect of the tibia. This line needs to be less than a half centimeter. If there is a step which is more than 5 millimeters, less than half centimeter, then I'm worried that there is a fracture somewhere. The alignment of the tibiofemoral alignment is not right. So most of the time it's a lateral tibial plateau fracture, like this one, and most of the times you will have a lipohemothrosis at the same time. So if I looked at this one, the previous one there, with the lateral one, if I look at the AP, this is what I see here. So that's why you need 2 of the x-rays, not the 1. Okay, so then you look at the tibia plateau. The tibia plateau, then you can have small fractures with not very obvious, but you can see it, this is not very small. There's the tibia plateau fracture. So then again, with lateral x-ray, you could see some fusion as well. This is the second fracture, which usually seen in adults, but now we see the older ones. I thought just to include that as well. It's just a small avulsion fracture to the lateral tibia. It's very small, and usually it just causes swelling and quite tenderness. It's very rare in children and more often in adults. It's all the same there. Okay. The physeal fracture, looking for the tibial physeal fracture. Again, I'm sure you all know the Salter-Harris classification. I'm just going to go quickly through it. This is how it looks, a normal knee looks. I hope you all can see. It's not very small. Type 1, it goes through the epiphysis, and it's like only. Type 2 just goes, do you want anyone to tell me the classification, or just shall I go through it quickly? I'm sure you're all happy with it. Yeah, okay. So yeah, shall I go through it? Yeah, okay. So that goes below, that goes up, that goes through and through the fall, and then the fall is just it's all gone. Okay, so there is another fracture that we need to bear in mind, that sometimes with the infants it's almost pathognomic for NAI, is these bucket handle fractures. We see them in less than 2 years old. The Salter-Harris 2 fractures, and they can be caused by shaking or twisting injuries. And when they are older, you do a regular safeguarding pathway. If you have other concerns because of the behavior of the parents or anything, you just raise more concerns. You deal with it, but they look like bucket handle fracture. That's why they're called like that, and they're quite pathognomic for NAI. Not to miss this one. Okay, then we look at the intracondylar eminence. So the intracondylar eminence is most of the times it's a avulsion fracture because the anterior cruciate ligament is attached on it, and because it's a strong ligament, then it just causes the avulsion fracture. You're going to have joint infusion again with them. Sometimes you may not be able to see it on X-ray, but you'll be able to see the effusion. There are like 4 types of them. One is just non-displaced at all, mildly displaced, type 2, completely displaced, or many compartments of the fracture on this one, on the 4, which is more serious, obviously. This is an X-ray of type 3 looks like. It may be a little bit, if it was type 1, you may not be able to see it, but you would be able to see the effusion on the lateral one. Okay, and then the patellotendon disruption, look at that. So if you measure the patella, the length of the patella should be same or plus minus 20% of the length from the from the width of the line, which goes from the lower pole of the patella to the tibial tuberosity here. So these lines should be same or plus minus 20%, and it's called insole Salvati index. Normally it's 1. Patella can be fractured in 2 pieces, in 3 pieces. You see the blood, the fat, lipohemothrosis. It's definitely it's going to cause it's quite a big fracture. They're quite obvious, and then you need the orthopedic to come down and see the patient. So yes, the patella has a sleeve down here, and it can be fractured. They look very small and they look innocent on the X-ray, but they can be very serious. It usually happened to age of 8 to 12 years old. They can cause significant disruption of the articular cartilage. And usually they happen from quadriceps contraction, like sudden as jumping. So what they are just avulsion fractures, again, of the inferior pole of the patella, including the cartilage from the articular surface. That's why they can cause problems with the articular cartilage. So you will see the high-riding patella, the avulsed crescent-shaped fragment, which is localized swelling around the lower pole of the patella. And there's no joint effusion in this one because it is an extra-articular fracture. Okay, some people, they have patellas who are, they have 2 bones making a patella, which is normal. You can see this one they're soft. It's not very often, it's quite rare, but you can see it, especially to smaller children, and some of them, when they grow up, it just comes together again. But some people, they have that. It's quite rare though, but it's good to know that this can be a normal variant. Okay, so do they need referral to be seen by ortho team? There are so many of them, not all of them need to be seen, but the ones that are unstable and the fractures around the knee, they all need to be seen by orthopedics. And the ones that, as we said, they're more unstable are the ones that they cannot lift the leg up. When they cannot see the fracture very clearly, but they can see a big effusion, they do prefer to do MRIs for children. But the stable injuries, the ones that they can weigh bare with a splint and crutches, they can be reviewed later in the fracture clinic. Usually we just put the fracture clinic refer and they decide, but it's good if they can see them in a week. So the swelling has come down, the pain is better because the swelling has come down, and then they can examine and do more tests if they need, or they can just discharge them a week later when they're happy. But I would suggest refer them, if you're worried, refer them to fracture clinic for another view. What is our treatment when we send them home? We put the cricket pad splint. It's quite easy to put it on. Instruction how to apply it, or you can find on EM3 as well. Organized follow-up, as we said, fracture clinic referral. I would suggest to give them crutches as well, so not too weight bear. They can rest a little bit with, they can take it off sometimes, so they can have a shower without it, with some help. They can, if the pain is increased, if they feel that it is not getting any better, to chase medical advice. I would always say to parents, and they always, I think after they see it from fracture clinic, when we refer them, they just give them some exercises for their knees as well, and they can some like physio at home. It's just some exercises for knee. Complications from them, I wouldn't go through its injury and complications, but I would say, because it's quite important for children, we see knee injuries but don't know, and then they say the knee is painful, but the child is too small to speak to us to explain, but they just point to the leg, they don't know. We've got the limping child, we know that. So do examine the hip. If you can't find anything, they complain for knee pain, and the 4-year-old can't find anything to the knee, examine the whole leg. Hip injuries, hip joint pathology in general come with referred knee pain most of the many times. So please do examine the hip as well, especially when you're very, very happy that nothing is going on with the knee. Okay, fractures of the tibia and the fibula. Sometimes they can be a mystery. Okay, so again, we'll go through the questions. How common are they? Tibial shafts are from the long bone fractures in children and adolescents, the third most common. 30% of the tibia fracture is associated with fibular fractures. So at your X-ray, don't be distracted. I'll discuss that later, but don't be distracted by a fibula. By tibia fracture. Look at the fibula as well. Okay, how do they occur? Again, they're falling down, they're running around. They can have direct injury as well, which is causing usually transverse fractures. We've got the toddler's fracture, which is usually rotational. We look at them, usually we see them 6 months to 3 years of age. Most of the time is a twisting force. The tibial shaft fractures can be classified, and we can always just describe it, write it down according to location. So is it proximal, is it in the middle, or is it distal third? The fracture pattern, is it transverse, is it a spiral fracture, or is it a comminuted or open fracture? The transverse fractures and the usually the ones that from direct blow in older children or road traffic accidents. The rotational ones that they will injuries they will cause spiral or oblique fractures usually. And then don't forget to look the involvement of the fibula, as we said. What do they look like clinically? So again, they're going to come limping. They're going to come even without any noticeable injury. We can see the toddler's fracture just all of a sudden they started limping. A good test to do on your examinations for a toddler's fracture, and don't forget that on a limping child, is having the foot on dorsiflexion, and then you just push and just rotate the foot as you hold the knee with one hand, on dorsiflexion with the other hand, the foot, and then just rotate. That will cause a lot of pain if there's a toddler's fracture. It's a good test. Do they need X-ray? Yes, they do need X-ray. What's the problem with the toddler's fracture though? It's so, usually the fracture is so tiny. Sometimes you can't even see the fracture. It's all normal. But if you have no other, you've examined the child hip to foot, there's nothing wrong with the hip, you have full range of movement of the hip, there's no tenderness around the hip, the knee looks fine, the femur is fine, and you only have that pain when you do that examination on the tibia, and you suspect it's a toddler's fracture. You can't see anything on the X-ray. I will bring them back for a repeat X-ray. And some of it, and then if it is a toddler's fracture, you can see the fracture. Then you can see the callus and the, you can see the white bit here and the callus that is just forming there. Okay, some fractures from tibia. So we've got an undisplaced, complete isolated tibia fracture. The fibula is fine, it's just isolated fracture there. It's a mildly displaced fracture of the tibial shaft here. Again, it's spiral piece 1, and then you can see more displaced tibia fracture there. And looking carefully to fibula, you can see a proximal fracture to the undisplaced fibula fracture to the fibula there as well. So always look at the fibula. Do they need to be seen by ortho team now? So if it was a fibular fracture like that, stable, undisplaced, I don't think so they would like to see them, or this one as well, an undisplaced fracture. If you're happy otherwise with the child, you just treat it and then they can go home with a fracture clinic referral. If it is a displaced one, they definitely want to see them. management. So if it is a stable fibular fracture, they can have the above knee back slap. We now don't do, we just do the cast straight away because of COVID, the things have changed. But in the past, we were doing back slap along this, if there was any swelling. If there's no swelling, to allow to come down so that you can put a complete cast. Yes, Jane, we'll do the soft wrap now. And even with the toddler's fracture, we always did a soft wrap. Even in the case that we couldn't see it, we do a soft wrap and then bring them back for a repeat X-ray, 10 days in the fracture clinic. It's quite difficult for parents, even the soft wrap. The good thing with the toddler's fracture and the soft wrap, they can, if they're able to walk, they can walk on it. But again, it's very difficult. Parents are very concerned, oh, I'm going to do that. They're very active, they're going to be very grumpy. It is difficult for parents, and that's why soft wrap is quite good for the toddler's fracture, especially when you just suspect a fracture. Can you imagine, just immobilize, have 10 days, and then there is no fracture, but you've done immobilize the child. That would be a nightmare for the parent. Okay. Complications that we should be aware of, and advice we should be given to parents is, if we see any increased pain, to chase medical advice, because if the compartment syndrome is one of the complications, isn't it? And the pain will come first and the swelling will come later. So with the advice of, we've got leaflets to give advice about the cast, and that applies to all casts we do for treatments. For the proximal tibia ones, they're more prone to vascular injuries, but again, it's quite rare. And then when you have isolated tibia fractures, sometimes you can have angular deformity. That's why they need a regular review by orthopedics. And usually they see them in a week, and then they see them 3 weeks after the injury as well. Okay. So we go through the ankle fractures. Again, children are a little bit more different because they've got the growth plates for the ankle as well. 2 bones, easy, tibia and fibula, sorry. And then we need to talk about a little bit more about growth plates. I'll go through what the growth plate is. I know you all know. So it just helps me remembering on what stage we are. So there is, if we take it in like each layer as a stage in the life of a bone cell. So initially they're baby cells like cartilage cells, and then they just multiply as like gremlins, and then they have a zone of hypertrophy where they're getting bigger, they're getting fatter and maybe wiser, and then they've got the calcium to come on top of it, and then they start to look like a bone, and then the zone of ossification as they enter the midlife, these cells build themselves a home, which is the bone. Okay, so again, these injuries, as with other joints in children, more avulsion fractures, more likely to have it than ligament injuries, because the ligaments are quite strong. They can have growth plate injuries, as we said. Again, Salter-Hurst classification. Growth plate, the first type 1 growth plate is a little squashed. Then the crack, the type 2, the crack starts at the growth plate and goes into the bone of the metaphysis. The other one, the type 3, is the growth plate fracture that goes into the bone and then into the ankle joint. And is the type 4 is then they go through and through both sides. And the type 5 is when the growth plate has totally been squashed. Other injuries, most importantly for teenagers, we present with a special category of fractures that they call transitional fractures, and they call it like that because it happens at the age of transition from the adolescence to maturity, and it happens with the ankle. What is different for the ankle is that the closure pattern of the distal tibia physis has a unique pattern. So it starts centrally, closing centrally, followed by the medial aspect, and then finally goes to the lateral close, which causes some specific fractures for the teenagers. We've got two of them, Tillaux fracture and the triplane fracture. The Tillaux fracture is a Salter-Harris type 3. So it goes through the epiphysis and then goes through the physis and then down to the ankle joint. We'll talk about them in a minute as well. The triplane, they are Salter-Harris fractures type 4, and there are 3 parts. They've got 3 parts, 3 planes, and that's why they're called a triplane. The Tillaux fracture is usually after an external rotation. So the best scenario for, I would say both of them, will be a 14-year-old girl or boy who, let's say, was playing football, running to get the ball, and the foot was caught in a clump of grass, and the ankle went on an external rotation, and the foot remained plantar. So what are Tillaux fractures? So that's the best scenario I can think of for one of these fractures. The key thing is the external rotation of the ankle. The Tillaux fracture is anterolateral distal tibia epiphysis, which tends to cause an avulsion fracture of the tibia fragment, and this is because the tibiofibular ligament here is a very strong ligament who goes from the anterior aspect of the lateral distal tibia to the anterior aspect of the tibia, of the fibula there. So that pulls out on the external rotation. It's the same mechanism, but you've got 3 sides of the fracture. You've got the metaphysis as well on this one, and you can better see it on the lateral X-ray. How common are they? The distal tibia is the 3rd most common physis to be injured. Salter-Harris one of the fibula and is the most common, and sometimes we miss it because it's just very tiny. You can't see it sometimes. And although those two transitional fractures account only 5 to 15% of the overall pediatric ankle fractures, they're the most common ankle fractures in adolescents. So we need to know about that. Okay, how do they occur? We talked about the transitional fractures. The other ones is any inversion, injuries, running around, playing, jumping from height, the ankle just landed in a funny position. They were just walking and then tripped over on the pavement, inversion injury or reversion injury. How do they look like clinically? The ankle will be swollen. Usually it is bruised, it's quite tender, they're reluctant to weigh bear on it, they don't want to move it at all. They come in, they ask for a wheelchair. You can see parents carrying them. Do they need an X-ray? Yes, they do need an X-ray. They don't need only one X-ray. They need 2 X-rays, AP and lateral. And sometimes to see these transitional fractures, you may need a more oblique X-ray, apart from the lateral one, just to see that metaphysis fracture there. If you are concerned that it is that, you refer to like a transitional fracture on the X-ray, they may need a CT, which it's up to orthopedics if they do that. Okay, radiologically, how do they look like? This is the normal ankle. The Salter-Harris ones, I'm not going to go through them again. I will have some examples here. Okay, so distal fibular fractures, these ones are quite stable, most of them, and they don't need orthopedic referral. We've got a smaller avulsion of distal fibula here. You can see this one. The Salter-Harris one of distal fibula, you can see that it's a little bit not greatly aligned. That could easily be missed, but then they may come back with more pain. And you can always immobilize them and bring them back to fracture clinic, because if they have that, you can't see anything, then you wonder, what is happening, why they cannot walk on it. I can't see anything. Is it something I'm missing? So all the time, I think the best thing to do, and then we tend to do that to Leicester, is that you just put a walking boot on them, and then you refer them to fracture clinic. There's another avulsion fracture of the distal fibula here, and this is a Salter-Harris of distal fibula. Again, stable fractures. Okay. As we said, it's very important to look for signs of instability. What you can do is check for the Tillaux tibia and fibula. If the talus is parallel with the tibia and fibula, if that line here of the tibia and that line here on the fibula, they are parallel with the fibula and with the talus, then it's stable. This is normal. And this is a spiral fracture of the fibula. So I'm happy, even if it is a spiral fracture, I'm happy to send them home and bring them back to fracture clinic. If it is not the case, though, another spiral fracture of the fibula, where you've got that talar shift. So you can see that the talus has gone towards the fibula, and you can see that gap is bigger than normal, and you can see that the tibia is not parallel to the talus. The lines are not parallel. The lines have gone. You can see here as well. Okay, so this is unstable, so this is what I would like orthopedics to see and probably manipulate. Okay, so you can see some medial malleolus fracture here, another one here, just some examples. A little bit there, a small one, and you can see it on the lateral one. It's better to see it on the AP one. Good. So this is a Salter-Harris one. So you can see that this is a normal, and this is the Salter. No, it's not the normal. It's the AP that you can't see it very clearly, but on the lateral one you can see it more clearly. The Salter-Harris 2. You can see obvious fracture there. Again, it's not on the one view, it's not always very obvious, so don't look at one x-ray. And if they haven't done it for any reason for you, you send the patient back. I wouldn't be happy just to send the patient home without having 2 or 3 views. Salter-Harris 3, fracture, it goes through and then, oops, sorry, it goes down in the articulate in the joint. Again, I would like the orthopedics to have a look because it goes in the joint. Okay, so for the Tillaux fracture, it applies for the triplane fractures as well. Most of the times you can see on the X-ray, but for the treatment that you see the orthopedics requesting when they see that, even when they're sure that there is Tillaux fracture, for the treatment, they need a CT because they can go more conservatively if it is a displacement is like this one, less than 2 millimeters, the displacement here, and they need to go to theatre if the displacement is more than 2 millimeters. So it's quite important to speak to the orthopedics as soon as you recognize it. The triplane fracture again on the X-ray. So you've got the vertical, it's through the epiphysis, horizontal, which goes across through the physis, and on the oblique or lateral X-ray, you can see the metaphysis fracture there. They're very similar. What you miss in the Tillaux fracture is you miss the number 3, the oblique one, the metaphysis fracture. It's just the epiphysis and the physis. That the Tillaux. The triplane includes the metaphysis as well. Again, here you can see the oblique, the epiphysis, the physis, the epiphysis, sorry, and then the metaphysis. Same here on the CT, more clear. And these are fractures that you don't see in adults, but you see them in teenagers, and they're quite important not to miss. Okay, do they need to be referred to orthopedics? As we said, if there is a Tillaux shift, if a displacement fragment, or if there's any you suspect transitional fracture, you ask them to come down and see them. All the other stable ones, you can treat them. If it is a distal fibular stable fracture, you can treat them with below knee cast, which can be a soft trap. Sorry, but if it is a tibia, they would prefer the above knee. If it is if it is a small fibula Salter Harris 1, you can put them on a walking boot, or if you're not sure, as we said, and then refer to fracture clinic. Yes, you do need to organize a follow-up with a repeat X-ray. 7 to 10 days is, I would say, for fibular fracture. But if it is a tibia fracture, undisplaced tibia fracture, I would say 7 days for fracture clinic for those ones. But then as soon as they see the X-ray, they decide when they will bring them back. For our department, in our other departments, you may need to say how long you want, in how many days you want them to be seen. What should you advise parents what to expect? They should remain not weight bearing until instructed by the orthopedics. Most of them, they have an outcome of a very good outcome, complete recovery, more than 85%. The complications that we should be aware, and then we should discuss sometimes with parents, so just to encourage them not to weight bear when we are concerned, is the growth arrest, and this is up to 20% of the triplane injuries. Again, the compartment syndrome, pain out of proportion, and then the swelling will come later. They need to contact fracture clinic. We need to give them all the details. If they can't get through them, ask them to come to us, or ask for medical advice, any kind. I think most of people, if they can't find fracture clinic, they can't speak to them, then they will come to A&E. Just for at most of the departments, they have a fracture clinic referral, like online, or they do it written down. In our department, don't forget the sticker as well, because it just needs. I keep saying our department. I'm not in Leicester at the minute, but I keep saying I work most of the time in Peds with Leicester. Okay, last one, the fifth metatarsal fracture. And I just chose to do only that one from the foot, because in adolescents we see them more often. How do they cure? Usually it's inversion injury, and it's usually an avoidance of the metatarsal tuberosity. Clinically, they will come like in pain. They may not weight bear on it, maybe bruising above the fifth like over the area of the fifth metatarsal, and the history would direct us as well. There is that Jones fracture, which is the proximal metaphysis, proximal part of the fifth metatarsal, which is more important, and they need more, a bit more, to be more careful for treatment. I will just discuss it in a minute. The other thing we just usually go wrong is that we are confused with the apophysis, that it comes like that. Remember that a Jones fracture, the fifth metatarsal fracture usually is the transverse. So at the proximal shaft of the fifth metatarsal, yeah, proximal there. It's transverse, and most of the time this is the normal apophysis. Do they need to be seen by orthopedics? Usually in a week's time, they need to be seen in fracture clinic. They don't need to be seen in A&E. Management, of course, pain relief as all fractures. We can give them walking boot with crutches, and the Jones fracture, though, should be mobilized in a non-walking boot. That's the only difference. So that's this one, because it's more unstable than all the other ones. Fracture clinic referral. The outcome is very good. It heals to 6 to 8 weeks. The The weight bearing is allowed as tolerated, except for the Jones fracture, and refracture or non-union are reported in literature, but they're quite rare. We don't see them very often. Okay, and yeah, that's a quick reference to the fifth metatarsal, because we do see them, because we see more teenagers recently, isn't it? Any thoughts? That's from my point of view. I hope you're not tired now. There's a lot of information. Some of them that you already knew, I'm sure. Some of them they may be new for you. Any thoughts? Oh, sorry. So if children present with hip, knee, ankle, or foot pain or traumatic nature, except septic, what would be the problems? Do we need to worry about any metabolic or autoimmune disorder? Okay, so it's a very long discussion that. So because we were talking about only injuries today, that's why I didn't include, because it was injuries related. But to worry about metabolic, you need to worry about several things. For hip, I think, I don't know if Sarah, are you going to talk about?
I think atraumatic limb pain is a whole other topic.
Yeah.
I think broadly speaking, if you Google UHL limping child pathway, that's got a really good flowchart on it, and I'll find the link and share it, going through how you manage the limping child, the atraumatic limping child, and the general principles are applied. So for atraumatic hip, knee, ankle, foot, it's unusual to get arm pain. Actually that they are a different type of patient, and then there's other things that you need to be thinking about, which is sort of out of the scope really of the injury talk that we're doing today, but I'll find the guidance and pop it in the chat for you.
The other good resource for is it Don't Forget the Bubbles. They've got a nice one there as well for the limping child.